some slides.
Yep. So you're okay with me recording this? Is that okay?
Yeah, absolutely.
Fantastic. Wonderful. So I think, when I'll sort of introduce you and then we'll launch into and take questions. Yeah. So thank you everybody for attending tonight's wonderful session, a very exciting session that will be delivered by Professor Helen O'Connell AO, who is with us tonight to share her experiences and insights on the female genital anatomy. Now, Helen O'Connell, for many of us here, is a familiar name. We have been impressed and we've all learned from her research on the female genitalia, and the clitoris in particular was the first female urologist in Australia and New Zealand, and then did her training in urology after a master's in women's health, exploring urge incontinence, and has been awarded this year with an Officer of Australia for her excellent service to the field of women's health, medicine, advocacy, and a multitude of other facets of health, and continues to make enormous impact on outcomes for women and men, and is a terrific mentor to others and also to young students, and is here to talk to us about her journey. Before we get started, however, I'd like to acknowledge the traditional owners of the land on which I'm on, which is the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging, and acknowledge that we're all meeting from different parts of the world here in this instance, and other parts of Australia. So, I just acknowledge the time that you've all taken to attend tonight, and look forward to having an animated conversation after Helen shares with us her presentation. So over to you, Helen.
Thank you for that very warm introduction. Oh, we've still got some screen sharing issue here. So having had to log out.
Okay, that's okay. In fact, I will do that again. I will help you. You are now a co-host, Helen. So someone has something on in the background. Roz, do you by any chance have? If that's right. If anyone's not speaking, please mute. That's right. Thank you.
Beg your pardon, everybody. I will just have this all nicely ready to go, but the best laid plans. Okay, let me get this sorted.
That's all right. So it would be great if you could introduce yourselves in the chat box there. So maybe where you're from, and also we have some names here that I've not seen before. So it would be great if we had some introductions in our chat. This is intended to be a really informal session where we all get something personal out of it, and enjoy learning about the experiences of someone who's had an amazing career path, and terrific. Okay.
Right, well, after that stellar beginning, and thank you for your patience, I must say, talking to a group of senior colleagues, I can see a number of gynecologists, just a really stellar group of people on this Zoom call. I'm so excited because I I usually have to tone down the language. I don't mean my swearing, but, you know, it's unusual to be able to talk freely about anatomical structures. I really hope that you become as passionate as I am about this issue, which I'll allude to, something we've started to call clitorisy, because as you will see, this is not just about anatomy, this work. Now, will you advance? So I would like to pay tribute to the University of Melbourne's Department of Anatomy and Neuroscience. We've got Jenny Hayes on the call, and that department, you know, was just fantastic at helping me to brainstorm what we were finding, make sense of the dissections, plan the dissections to get as much as we could out of every incredible donation from the Donor Body Program. I have spent more time with cadavers than is really polite for a woman, but wow, what an incredible contribution those women made to our lives and knowledge. More recently, we've been working with the Cascade program, which is a rapid autopsy program, which enables us to get incredibly fresh tissue. So these women are donating their bodies prior to death so that we can establish some as yet unknown information about urethral anatomy. You know, a lot of people ask about the G-spot, which I'll not be directly talking about, but maybe we can have a discussion about that as well if there's time. And the Urology Society, Royal Melbourne Hospital, and some other scholarships contributed to this work. So this is the pelvic, there's a sagittal view of the pelvis from the textbook that we learned from as both medical students and as young budding surgeons. And as you can see, where the clitoris is in reality, in this diagram, there is nothing. So what's happening in the diagram formation is a sort of mental deletion of a particular structure. And it is very interesting, the history of this structure, because it hasn't just been neglected at a in terms of, or treated badly in terms of female mutilation, but we've also very much neglected it intellectually. You know, as a bunch of clinicians, we might look at a magazine and you can just see that this is not the vagina, this is the vulva. And then what is wrong with these images? So we've got some deeper structures, but nowhere in the vicinity of these slings is in fact the clitoris, which is sitting right there. So hopefully you'll appreciate this if you haven't been immersed in anatomy, because I'm aware that anatomy is now not part of the curriculum in the way it was for us as medical students. Caroline Da Costa, who's on the line tonight, commissioned this editorial, and we reviewed the literature. There's just such a paucity of information. This is in the Australian Journal of O&G about the clitoris. And so part of our journey as clinicians is to help the public move from critical or intellectual clitoridectomy. What we found in decades of research is that at every age, in every woman, the clitoris is a substantial multiplanar structure that comprises several components: the glands, which we're all familiar with, the paired crura, which form the body in the midline of finger-like projection about the size of the little finger, and the bulbs are the most misunderstood organ, said to be the bulbs of the vestibule. the vestibule being kind of a space in terms of concept, but the bulbs very much fuse with the other parts of the clitoris and are most logically regarded as bulbs of the clitoris. And then there's a pars intermedia, an area immediately underneath the vulval skin, which has blood vessels which anastomose with all these other parts so that it can work as a functional unit. The clitoris, as you'll see, relates intimately to the distal urethra and vagina, which does give you interesting insights into the nature of G-spot. And it's also an organ with a massive neurovascular supply, which has been omitted largely from our textbooks. So vulva as a concept, what does that mean? Translated, it means wrapping. And what is being wrapped actually? What is being wrapped is the clitoris, which is directly underneath the vulva in its various componentry. And so to the left, we see the bulbs in the blue. We can see the labia have been removed. There's a little marker in the urethra. This is the pars intermedia. This is a relatively fresh donor specimen, someone who died a few days earlier. And what's amazing about this cadaver, this is part of our G-spot study, was within about 15 minutes of having dissected out the clitoris very quickly, those structures had faded to grey. It's the most beautifully coloured organ in its natural state. And so we see the labelling here, the body, which relates to the pubic symphysis, the glands, bulbs, and this vestibular fossa, and you can see where the labia's cut edge has been. And I know Magda and others in related to this group have been campaigning against the senseless excision of female genital tissue through labiaplasty. But you can just see the relationship of the labia to this organ. This is a lateral view of the perineum, a dissection that shows the pubis in cut section. This is the pudendal nerve coming along, and then we see the huge branch, almost as big as a pudendal itself, which is the nerve, the so-called dorsal nerve to the clitoris, that then goes along underneath the pubic ischiopubic ramus, alongside the inner aspect of the crus, the right crus in this case, and then it passes along the top side of the body, which is boomerang shaped, very appropriate if you're Australian, all the way down to the glands of the clitoris, where it remains largely intact. And this is obviously an atrophic cadaver, but you get a sense of the size in an atrophic situation. Looking a bit more closely, we see the relationship between the bulb. This is sitting on the lateral aspect or outer aspect of the vaginal wall. If you lift the bulb up, if you dissect that up, you will show the lateral vaginal wall. Those two things are inseparable. So you could put a finger in the vagina to feel the lateral wall, and you would have the urogenital diaphragm or perineal membrane, and then on the other side of that is the bulb, which is sort of hard anatomy to get your head around. But this is the beauty of studying anatomy, is that we get to pull things apart in this way and see how all these different parts relate. What's interesting about dissection, as we saw with that image of lasts, is that what you label is a value judgment. And so what is fascinating about this anatomy is that quite detailed anatomical diagrams were evident in the versions of Gray's at the turn of the century, 19th century. And then across the 20th century, there was progressive loss of labelling, only to start being relabelled again in the 1970s. So it's very interesting. You don't know whether this is conscious or not, but I knew as a young doctor studying this stuff that something social was really getting in the way of good science. The other thing that's interesting to recognise is that we can see the pubis, which is kind of locks a lot of this structure in and protects it. But the thighs also, our adductors, make all of this very inaccessible. So, issues of consent relate to access, and a woman has very strong adductors, which, so the adductors insert very close to the bulb. So if you, I'm not sure that I can show you in any of the diagrams I've got, but the adductors actually are inserting very close to this, but the layers of the of fascia are on top of it. We'll go on to have a look at the neurovascular structures, the relationship between the clitoris and vaginal wall, and different shapes of the clitoris depending upon age and reproductive status. So this shows a dissection without the pubis at all. So therefore you get to see that crus becoming the body, and the urethra here with the bulbs which join from either side and go up to the anterior surface of the urethra. What was really interesting at a meeting in India last year is someone used my dissections to show that you could actually protect the body of the clitoris by the fact that there is, particularly in the midline, on the anterior surface, a relatively safe area for protecting sexual structure. So it's really interesting that male urologists are getting on board with fundamental anatomy to drive the design of operations. Looking at the anatomical texts, I bought after I'd been working on the dissections for a couple of years, I bought a new a new copy of Gray's. Very excited as I unwrapped it to see what would it show, and it was unchanged. And I'll highlight a few areas from Gray's. This quote says, in the female, so they've gone into a lot of detail about the male dorsal nerve of the penis. And then having given all of that description, we then say the corresponding nerve, dorsal nerve of the clitoris is small and supplies the clitoris, and that's it. Like, that is acceptable as anatomical description. Well, firstly, it's completely wrong. And secondly, how appalling to just give male anatomy and then completely ignore what's going on in women. So this gives you a bit of an idea of, so this is ischiopubic ramus here, but Gray's was absolutely incorrect. This is a very substantial nerve, the dorsal nerve of the clitoris, as is the branch that goes to the bulb as the perineal artery and neurovascular bundle. Also, as you look at this histology, you can see this is the glands coming down to the, just move that across to the tip of the glands here. And you can see these huge nerve trunks all of the way to the glands. So you can see why it's an incredibly sensitive organ, almost in many ways too sensitive sexually for direct contact. There's also Purkinjean corpuscles for vibratory sense and a number of other sensory receptors in this section. See if I can move that over out of the way. And then I had the blessing of John Delancey, a guru of gynecology and gynecologic MRI, contact me and give me access to a bank of healthy volunteers and their MRIs. And so I'll be able to share some of those images with you. But you can see the vessels going over the top of the clitoris, and in a little bit of art from Levent Effie and the relationship to the urethra and vaginal wall there. And then you see just how brilliant the fat saturation image. This is, here's the crura coming up to form the body, projecting out into the mons pubis fat. You see the urethra and vaginal wall, which form kind of like the core of the clitoris. And together they make a pyramidal structure. So this is anal canal down here. See if we can get that up the top over there. And so this is pubic symphysis here, and we see the crura and the crura here, and then the bulbs as they wrap around the urethra, relevant to access to urethra, and we see the vessels coming along that pelvic sidewall, which can be injured during pelvic surgery. Why did I use inverted commas around the word dorsal? Because dorsal refers to the erect penis, and this is actually ventral or anterior, truly. So it is really interesting just how kind of misogynistic or male-oriented our basic anatomical structures are, even the naming of significant nerves. Gray's Anatomy said the clitoris is then, in many details, a smaller version of the penis, but differs in being entirely separate from the urethra. And you've started to see how this is completely false. It's not entirely separate from the urethra at all. In fact, you might, from a certain view where the labial margin's still intact, kind of see that that it looks like it's not related, but hang about a bit. And we published this in '98, which has had a fair bit of publicity. And you can see this is in a young cadaver, the labial margin and the urethra peeping through. But you know, from already having seen some of these images, what the relationship is to the urethra. So dissection is a delayering process. We preferentially keep or remove structures to explore the related parts and adjacent parts. And if the labial margin is intact, it's hard to see the urethra and its relationship to the clitoris. But MRI demystifies all of that and shows anatomy in a live state. So it very beautifully complements the dissection-based study. And so this is with fat saturation on the right-hand side, and on the left you see beautifully the detailed, the crura going up to become the body as they project into the body, into the mons pubis fat. You see the bulbs, urethra, vaginal wall, and you probably know this anatomy kind of at some level intuitively from your own experience, but MRI certainly enabled us to just show it so clearly, and how fantastic these healthy volunteers were able to enable us to see live anatomy. And so a diagram, a lot of people, fewer doctors, certainly to the lay public, it's almost impossible to show even an MRI. They certainly can't look at a dissection. Happily, I'm with trusted friends tonight, but in case you're someone who never liked anatomy and find it much easier to look at a diagram, this would help you understand the way that all fits together. And here's the ischium down here, and the pubis is not in this section. The section below, you can see the glands, you can see the body, the bulbs, again, the relationship to the urethral meatus and vagina. In a sagittal view, the clitoris doesn't show its relationship to the urethra as clearly because a lot of it rises up. So it's in three planes. It is on a oblique angle, its relationship to the vaginal wall. So you, in the sagittal plane, just see the little boomerang shape of the body, and then we've got the bulb partly shown there, but you can't see its relationship if all you look at is a sagittal plane in terms of the urethra. But here we see a coronal section from an elderly cadaver, and we see the body in coronal section here, the crura on either side, those nerves on the anterior surface. We see the bulbs, and you can see just how similar the structure is of the bulbs relative to the body. We see the relationship of the bulbs to the urethra and vaginal lumen in that section. So it starts to demystify what's happening during sexual function because you understand the relationship between these parts. This is a fresh dissection from a younger cadaver, and we've removed the body of the clitoris, but you see the crus in cross section. Again, the body, the bulbs coming up on either side to join anterior to the urethra. This is some work from the University of Melbourne, their Anatomedia. Jenny, no doubt, is a consultant to this group, but you can see how plasticine helps to accentuate some of these structures, and then lovely multimedia diagrams just to help medical students and other people interested in anatomy to understand how this all works. This view is as though the cadaver is kind of tilted up, but you see this bottom view is actually the true anatomical position. So this is how it would be for a woman standing. Just moving a little bit from the anatomy itself to some history to put this in context. Poor old Vesalius, who is acknowledged as being the father of anatomy, said of the clitoris, it was unreasonable to blame others for incompetence on the basis of some sport of nature you have observed in some women, and you can hardly ascribe this new and useless part as if it were an organ. Sorry, such a great quote, to healthy women. Must have had a terrible sex life, don't you think? So that's what Vesalius had to say in 1564. There was a lot going on. The fact that in Ethiopia, the clitoris had been excised for 2,000 years played into this, and his underlings had so-called discovered the clitoris, not that women would have ever known about it from their own bodies, but this is some of our cultural history. It was believed that Ethiopian women needed to have a clitoridectomy or some sort of genital mutilation because they had unusually large clitorises, and all women were regarded as abnormal and needing modification. Does that ring some sort of bell with our current situation? And what's interesting is that wherever Islam spread, so did the more misogynistic practices, though it was not exclusively practiced amongst Islamic people, and has definitely been practiced by sub-Saharan Christians. So these are some quotes from the other. I might, in the interest of time, move on to Isaac Baker-Brown, who was a leading figure in British gynecology in 1866, who wrote a book on called clitoridectomy, which he called his operation. And he said that all unprejudiced men must adopt more or less the practice which he'd carried out. And clitoridectomy was used widely in London and Britain at the time for indications such as insanity, epilepsy, catalepsy, and hysteria. Well, it took some time, but eventually the profession rose up against him, and he was in fact deregistered. He said that obstetricians, beyond other men, are not only the guardians of life, but by force of circumstance, often the guardians of female honour and purity. So it is very interesting to look at some of the cultural underpinnings that have led to our appalling situation, really, when you look at the anatomy that we were learning back in the 80s and 90s, and the kind of intellectual excision of this part. Elizabeth Sheehan, a feminist, wrote that the 19th century medical profession wanted it both ways. The clitoris was so unimportant to a normal woman to not be missed if it was removed. And yet lurking in its tissue was the greatest threat to female welfare ever known. And I mean, it's a really interesting metaphor for today, isn't it? That, you know, there is still a lot of questions raised about the importance of female orgasm. Why is it important? It's not necessarily critical for conception, as though every sperm that was ever ejaculated was important for conception. I'll just touch on the relationship to the urethra, so you can see how the meatus relates, and so quite a bit of surgery now is being done in this plane or directly above the urethra, or as much as possible we'll aim to go via the anterior vaginal wall if we're doing suspension procedures. But you can see how these organs relate. And you also see there the relative size with the ruler in the lower part of the picture. And so this is some surgical art that highlights that the tendency to still do a deletion of this really important body part when we're showing surgical diagrams. And so hopefully over time this will be a thing of the past, but you know, clearly in the vicinity of that sling lies the clitoris. This gives you a bit of an idea. So I talked before about the adductors. So the adductors come off the margin here. So we are very close with the crus here to adductor longus, gracilis, you know, the muscles that would protect this organ from harm. This is an elderly cadaver. This is a woman who died of a parotid tumour in her 30s. And you get to see the difference that atrophy makes. And certainly most of the elderly cadavers, the bulbs do tend to be the most atrophic part, and they often will rise in an anterior direction, sometimes being, you know, as short as 3 or 4 centimetres rather than the 7 or 8 centimetres in a young woman. I don't think there's any doubt if we're going to communicate with the masses that we need great art. And this has been embraced by artists. This is a documentary put together by a French TV network with myself as a consultant. It was bought by SBS. It is actually now on YouTube, but you get to see how art really makes this information much, much more accessible. I'll get that to the top of the picture, but you really get to see the relationship to the vaginal wall in you know, you get rid of all that blood and all that other structure that most people can't handle looking at. And here's some images of some sculpture. This is a Melbourne-based sculpture. You can see the bulb. This is obviously in stone, and the labia. Sophia Wallace, I invite you to watch her TED Talk. She did this stunning sculpture, and there's some other magnificent pieces of art out there. I'm happy to, if anyone is interested in looking at some of the art that's been done. This is really starting to gain traction as a beautiful structure in its own right that we should all celebrate. In the literature, there's clearly a lot more information coming out, and Melissa Fyfe won 2 major literary awards for this piece in the Sydney Morning Herald and The Age. And cliteracy is a societal movement that we should get behind, which is fed by science, art and literature to help women and men move from bodily harm to awareness and joy in an organ that was designed from the get-go with bodily pleasure and intimacy in mind. Very happy to take questions. Thank you so much for joining me for this presentation. I hope that you can find it relevant in your daily life.
Wow. Oh, thank you. Thank you. This is a stunning piece of work you've presented to us. It sort of looks like a lifetime of immense focus and research. And from when you first did your fellowship and your research in genital anatomy, this has just continued on and grown. I mean, I've learned so much today, and I thought that the work, you know, did earlier on labiaplasty that I knew, but this was remarkable, Helen. So thank you for the detail and for guiding us through the anatomy. It's a really complex area, and you can see how easily it would be for a surgeon who didn't have that understanding and sensitivity to do damage. Yeah.
Yeah, look, I think there's a lot more work to be done with this, and you know, I think we just we are getting better and better as surgeons, and you know, including gynecologic surgeons, at increasing refinement, accuracy, you know, minimizing collateral damage. You know, there's obviously, I mean, I was pretty horrified as a young resident at the sort of standards of surgery that were being done in the mid-80s. And, you know, it's so much better today, but I really feel optimistic at the way, for example, Jeremy Oates for the Fundamentals of O&G invited me to write the anatomy chapter. He was very open to Norm Eisenberg being a collaborator on it. And just, you know, that kind of willingness to see something like this as important, and even though it's kind of new anatomy, that it needed to be in there. So, you know, it's a good moment in time, really, for women.
Mm. Now, given that we have some time, I would like to invite members of the audience to ask Helen some questions, and we'll take them. If you could put your hand up, and I'll give you the opportunity to ask Helen some questions or make some comments in relation to what you've also gained out of this. Philippa, was that a request?
Yes. Hi, Helen. Great talk. Thank you very much.
We're medical students together.
Yeah.
So great to see you.
Yeah, you too. So I read, this is a bit obscure, but I've got a question about labiaplasty, because I read in a medical student ethics essay, which I was marking, he described this case where labiaplasty had happened in a peripheral hospital, and it was described as being, harmless to the woman because the labia are just, thin flaps of skin and they don't contain anything.
Mm.
And so my question is, do some women have clitoral tissue in the labia minora, or is it variable?
Yeah, it is a very interesting question, and I haven't specifically focused a study on that, but I'll just make a few observations. In the fetus, the female fetus, at 9 weeks, there's a phallus in both sexes. The phallus becomes labia minora as well as clitoris. It is by no means skin. So I do have I've got some histo on the labia minora. The labia majora are pretty interesting because they're obviously very vascular and they tend to get less vascular over time. But there is no question we are excising more than skin in this endeavour. And the really tragic thing is just, you can see with youth and with, someone as old as me, that the labia minora shrink and they're nowhere near as beautiful as they are, like the beauty of the clitoris during that reproductive phase. They are beautiful and generous, and then someone's got this fanciful idea that they should be miniature and infantile. Well, how sad is that?
Tragic. Well, I just put it down to the whole diminishing women. Like I've just read a novel called A Lonely Girl is a Dangerous Thing. And, the boyfriend won't touch her until she's shaved her pubes.
Mm.
And, it's just doing gynecology as I do, and transvaginal ultrasound and all of this. I mean, there's a whole generation out there shaving their pubes. And
I just think we have a huge job ahead of us to make women proud of what they've got, to make them love their body and not be vulnerable to Desiree's talked about infantilism. It really is, but you don't need to spend too much time on a porn site to realise just the extent to which women are degraded in the name of sexuality. To turn this into something good, man, we've got a task ahead of us.
Well, yeah, I think I've been working on that for a while there, Helen, haven't you?
Yeah, you have, Magdalena.
The incidents and the rates are still escalating. Now, Shiva has got her hand up here. So, Shiva.
Prof. O'Connell, thank you so much for such an excellent talk. I feel like I've learned a lot tonight. My question actually is on the topic of what's, I guess, normal and not normal. And like having a look at resources, like I think the Labia Library are excellent resources for young women to have a look at and know, I guess, what to expect or what's normal. In that same vein, I'm not sure if this is research that you've come across or done yourself, but have you noticed any differences in clitoral anatomy between women of different ethnicities?
That is a really good question. Some of the healthy donors I know were African Americans. The donor body program, I have to say, is pretty elderly white gals, and that beautiful young woman was a white woman. So it's a really interesting thing. My understanding is that there is no difference, but interesting to look at it in more detail. There's been a fantastic study in Spain in recent years, and the histology findings and the dissection findings looked the same. So bit of an idea.
Thank you.
Good question, Shiva. Yeah. Carolyn.
First of all, thank you so much, Helen. You and I have spent a bit of time together in the last year or so, and I've seen some of your information, but I'm absolutely overcome with what else I've learned from you this evening. It's just amazing. So thank you for that. In regard to differences in ethnicity, my experience in 45 years of practicing medicine is that everybody's different. Noses are different, arms are different, they still work, hands are different, penises are different, vaginas are different. I've seen a lot of vulvas and vaginas and so on, and they're all different. And it's really how they function as much as how they look, isn't it? So I doubt that there are sweeping differences in ethnicity amongst clitorises specific to ethnic background.
Yes.
Yeah, I'm sorry, I was a little bit late. So I don't know if anybody covered why it took a urologist, not a gynecologist, to do it. I've reflected on this for ages after your fabulous work, because I did graduate in 1987. So, and I didn't start O&G till 1992. So I always wondered, but I did find the answer in one of your interviews as to why it needed to be a urologist, not a gynecologist, because I don't know what Caroline would say, but, you know, I just believed what I was taught, and I had no reason, if you know what I mean, to question what I was being taught. So, you know, very grateful to you for that. In terms of, I guess, the question about how are we all the same or different, I always tell my patients, you know, especially when I can't find their cervix, that, you know, it's like faces. Everybody has a nose and nostrils and eyes, and, you know, I basically know it's here somewhere, and I just have to find it. And I think that's kind of also the answer, isn't it? Is that there will be variation, as Caroline said, but, you know, we're always expecting a nose, two nostrils, some eyes, a mouth, you know, when we're looking.
Yeah, that's absolutely right. And I have the joy now of being on the same floor as Des, and, you know, had massive joy from discussing a case with her in person, you know, during the last month. But I was just going to say the serendipity or kind of weird thing with all this, and I'm not sure if you saw it in the interview, but I really don't think if I'd passed my first part the first time and not had to study that wretched book over and over, that I would have got as incensed and as fired up about how important it was to do something. So you're probably a better student than me, Des, and you would never have failed an exam and had to
Oh,
learn
no. I'll
anatomy
confess
twice.
that I failed my first part 3 times, but got the second part. No, I think it's a really interesting thing about, how you come to think about an idea, because I did, not to take hold of this whole discussion, but 2 of the things that drove me into obstetrics and gynecology was, one, at my very first lecture being told that women had an IQ of 2 because they couldn't remember the first day of their last normal menstrual period, or that we were about to find that women had an IQ of 2 for not knowing that date. And of course, that really watching a baby birth is just such a blast. But there is something about that paradigm that we were all enculturated into, that somehow you didn't think like that and we all did, even though I was sensitized at the time to the sexism in O&G, if that makes sense. But it just never occurred to me to question the anatomy of the clitoris. Let's face it, that's what you did, and it's a great gift to everybody, isn't it, ladies?
It's a great,
very generous, Des.
Yeah. Well, it's true, and I think that we're as this is the next phase of it all now, Helen. So clearly, what the world is ready for is sort of emancipation of this particular organ, and this conversation that you started a long time ago now, is very mainstream, and in a way, the celebration of this forgotten piece of anatomy that distinguishes the female sexual experience and function from that of any other. And I think that in an environment where there's very little, it's not sacred anymore, that female part. And I think that what you've identified in its uniqueness is that there is something really special about this organ, and that only women have this, and that its sole function is for pleasure. I think that there's something really deep about that to ponder, and that is probably a message that maybe the world is getting ready to hear, because the labiaplasty industry is escalating, and in fact there's more and more literature coming out now about the lack of or the lack of complexity or the lack of complications, and that there's patient satisfaction and that genital function is unaltered. However, what you've addressed also, which I've often talked about with my patients, although there's been very little literature on this, is that genitalia does atrophy with age, and this is sensitive tissue, and if you're already sort of, you're aging and that surface area is being reduced, then it sort of makes almost logical sense that the surface area that gives you contact to this particular nervous structure is also going to reduce in some ways, and therefore maintaining what you've got is really important.
Yeah, definitely.
So is there a difference? Oh, sorry, Carolyn.
Well, I was just going to say that, yes, I think exactly what you said, Magdalena, is very important. I'd just like to say how much more I think obstetricians and, obstetric and gynecological trainees need to know about the clitoris, and I think it needs to be mandatory in their first 4 years, and I intend to try and make that the case. I was very late getting to Helen to get her to write the editorial for the obstetricians and gynecologists once I realised that the word clitoris really didn't function, it didn't appear anywhere in our journal or in other journals at all over the last 2 decades, and there wasn't much point going beyond further back than that. And so I was very grateful when you did the editorial for us, Helen, and we've also had one on labiaplasty since then. One of the things I noticed was we have a president, a male president, who's very, very good. He's very keen to connect with the obstetricians and gynecologists of Australia and the trainees and the diplomats. And we get a Connect newsletter every week, and it contains everything of interest to obstetricians and gynecologists and everything that I have in Anne's jog. But amazingly missing from it in the same time frame as we published the Helen's editorial, and she appeared doing a podcast on The Guardian, and it obtained some other publicity, we did not hear anything about the clitoris. So we've got a way to go.
Yeah, that mental deletion is amazingly kind of strong, isn't it? And it is, I mean, I think that Isaac Baker Brown stuff is really telling, don't you think? Guardians of Female Purity, and that if you're, you know, sexually active or enjoy sexuality, you know, you're not a chaste woman and you're somehow defective and you haven't been guarded properly. You know, so it's very complex culturally, but you know, we're educated people, we've got to make things better for the future. And there's a ground, you know, you think of that Mexican festival who invited you and I, Caroline, to speak. There's a groundswell in the community that's actually running ahead of the medical profession at the moment. The medical profession is going to be brought kicking and screaming to cliteracy. It's pretty cool.
Well, that's all thanks to you, Helen. So, yeah, well, yeah, because I mean that's the seminal work, and that's the landmark research. So, and it's great that it's a female leading this too. So let's add that to the whole discussion too, because to date, let's face it, most of the anatomists have been males, and it feels like the clitoris is back in its rightful home in the you know.
It would be nice to ask Mrs. Vesalius what she thought.
That's right. Oh, he's hopeless in bed. Doesn't seem to be able to find anything.
It reminds me of, you know, 2 years prior to getting breast cancer, I went along to talk to a breast surgeon about prophylactic mastectomy because everyone around me was getting breast cancer and I was starting to get nervous about it. Anyway, she said, oh, really, you don't want to do that, you know, because it cuts off all the nerves to your nipples and your sex drive and your sexual expression will be really profoundly affected. It's not just a, you know, it's not a benign procedure and you don't have breast cancer yet. So she was onto it. And I just thought, well, no, you know, this essay that I read about the counselling prior to this labiaplasty had nothing mentioned about sexual satisfaction or the impact on it.
Well, they wouldn't want to know, you know, they don't want to ask those questions. They ask questions about general satisfaction and, of course, the look in the mirror.
Well, there seemed to be the only things they went into was how big would you like them left? That was all about the appearance.
Yes, I've got two things. One's for Helen. Helen, my understanding is that the pornography regulations in Australia are very clear that they must not show the clitoris nor labia minora in any of our publications. Have you looked into that issue and the aspect of whether we ought to be doing some advocacy to have that type of regulation removed from Australia?
Oh, wow, Gay, that's such an amazing point.
There's an enormous amount of people that have actually got a career out of just sitting there and erasing the clitoris and labia minora of all the photos before they get published.
Wow, that's such an interesting angle. I know that sometimes when I'm sending academic emails, it'll be blocked by certain university sites or hospital sites because of the word clitoris. And that is a really interesting piece of advocacy that should be done.
That's what the boys and girls are looking at. They're looking at the literature in magazines and online, and they really must remove the labia minora and clitoris before it can be published. And
wow.
So it's something worth looking into. That's one thing. And my second thing is I'm from Melbourne Uni, and I'm wondering how many of the people online are still wandering around Melbourne Uni as a geographic location. And could you tell me what percentage of buildings in Melbourne University are named after men and what percentage are named after women? and whether there is any difference across Australia for all the universities. I know Sydney University and Uni of New South Wales, which is a new unis to me, all I look at are male names on every building. And I'm wondering whether that's something we ought to be looking at and being more proactive, because, for example, Melbourne Uni is building a lot of new buildings, and I'm wondering how many of them have got women's names, and whether we should have a quota for the universities as to women's names on buildings where our young students across all faculties are walking in and out calling the buildings by these wonderful men's names.
You are a great advocate, Gay. I have not thought of any of these things. That is such clever stuff. Look, it's really interesting, isn't it? The influence of women in the world. I love it, the idea that we just take pride in stuff. Yeah, what a great idea.
What about wards in the hospital? Did most of your wards have, there's some of the older hospitals actually have names to their wards, like the new ones. I wonder if they still have male names as well.
Mm. Oh, we were just talking earlier in the call about, just the wonderful things that, the early medical women did in Australia, the feminists in other walks of life. We have so much to be proud of, and it is appalling, isn't it? The lack of representation on buildings. I've never thought of that.
Yeah, if you don't see it, you don't believe it, and it goes back to that, doesn't it? So they're really important points. So we've come up with a few really interesting new advocacy items tonight. We've talked about clitoris, we've talked about names on buildings, we've talked about the censorship of the female genitalia and talking to the censorship board, and we're talking about educating our medical fraternity and maintaining the importance of the clitoris as an entity, as a separate special organ in all anatomy texts, and as Carolyn has said, to take it also to RANZCOG, to make them acknowledge the work that exists already, and to perhaps have a site because in fact maybe that is what's required with RANZCOG, to have an actual site that with an active program to address this paucity in understanding, this lack of understanding, this big gaping absence of knowledge around the clitoris amongst gynecologists and obstetricians, so that we just inform them in one massive campaign, and it could be instigated through RANZCOG and VJ Roach, who is pretty cool.
Can I raise a hand? Yeah. Just adding a point, getting back to Gay's comment, role models are incredibly important to the young. I had the fortune to be trained at the old Queen Vic, which was the hospital whose motto was by women, for women. And we had female heads of unit and female senior lecturers and female professors. And that in the 70s, when I was training as a medical student, was incredibly rare. And I think you have to see something to know that you can do it. If you see senior women taking charge and doing things, it becomes a very positive information in one's career planning. And I think that's something that things like the Medical Women's Society are for. We range from medical students to very senior citizens, and we're all working to the same end.
You have definitely been a great role model, Kate.
Thank you. And Anne, who's on the webcast tonight, Anne Myers, who was, she mentioned earlier that she graduated in 1952, which was 2 years before I was born. I had a wonderful exposure to older women doctors who had run the world the way they wanted it. And it was an inspiration to me as a junior.
Yeah, it's an exciting history, isn't it? Melbourne medical women, you know, yeah,
Society.
amazing.
Yeah, yeah.
It's 125 years.
Mm.
Mm.
Yeah, yeah. Well, I'm really overwhelmed by what we've witnessed tonight and what we've all learned. And I just want to say thank you, Helen, for this event and for giving us such detail, because that is really something none of us has seen before. And I am really impressed by the complexity of this organ and the importance of the whole orgasm and process. The whole responsiveness is all around that, and that just makes it all the more important for us to wonder why we don't acknowledge it more and work towards it being a standard part of our teaching. So, Helen, are there any parting words or any final comments you'd like to leave us with for tonight?
Oh, look, it's just been wonderful to be with colleagues. So, no, look, thank you very much for including me. You know, I have a special place in my kind of psyche for my medical mentors, female and male, and, you know, to see all of the great people on the call tonight, so, you know, a great honour for me. So thank you for taking interest, every one of you.
Well, you've inspired us, Helen, so thank you. Thank you so much. And
Thanks,
we'll
Helen.
keep in touch. Yeah, thank you. Now, can I just take a photo of all of us as we are? Marissa, you're taking a snapshot? I'm going to take one with my phone and with my camera.
If people could turn on their cameras, even if they're in their pajamas, that would be nice.
Yeah, that'd be great. Yeah, switch it on. You too, Alison. Doesn't matter if you're PJs. That'd be great. And thank you, Alison from the USA, who's attended today and joined us. I hope you got something really, really special out of this. Alison, we're going to see you?
Oh, it's a tough gig at 5 in the morning.
Okay. I'll grant you that. Terrific. Okay. Taking a shot there. Marissa, thank you. Thank you so much. Okay. You can have a rest now, Helen, after your busy day.
Yeah, it's been a big day.
Yeah.
I'm sorry I couldn't organise a haircut before the meeting tonight, but it seems to have been a bit of an obstacle.
Well, thanks so much, Helen. Thanks a lot.
Bye, everybody.
Bye.
Thanks, Magda. Thanks, everyone. Excellent evening.
Thank you. Yeah.
Sorry I was late, as usual.
Absolutely, darling. Yeah. Bye, everyone. Thanks, Marina, for coming. Fantastic. Fantastic seeing you. Thank you, Rosalind. Thank you, Rose. Ira, thank you for joining us. And Alison, you're still there. We can have a bit of a chat if you like. Catch up on what's going on in your neck of the woods. Bye, Deb.
Bye-bye. See ya.
Bye. Anne, I think, has gone off to have dinner, so that's okay. How are you, Alison? Can you hear me? Hi, Alison. You there?
Yes, I'm here.
Hi, how wonderful. I'm so glad you're here.
I was trying to find Zoom on my phone.